or the other. So no financial interests to disclose. In keratoconus, yes, as the keratoconus progresses, it finally reaches a stage when the patient may not be able to successfully wear the contact lenses. Although people who fit scleral lenses would say that there is no cone that cannot be fitted. But sometimes the patients are not comfortable and they look for a more permanent modality of treatment. So then we look at surgically trying to restore the corneal anatomy. And we have been traditionally, we are quite familiar with penetrating keratoplasty, where you remove a corneal button full thickness and replace it with donor tissue. Over the past decade, we have seen a resurgence of anterior lamellar keratoplasty, and it's basically indicated for any condition wherein the decimus membrane and the endothelium is healthy and there is no scarring. There are various techniques you can do, either a manual layer by layer, or using the automated keratome or the femtosecond laser, or the stromal injection of air or viscoelastic to separate the decimus from the pathological stroma. Advantages of anterior lamellar keratoplasty is that you retain the healthy host endothelium, and that takes away the risk of endothelial rejection. You need to use steroids for a much longer, much shorter duration of time, and you don't have an open globe during the surgery, so intraoperative complications are minimized. And because the risk of rejection is not there, you can use much larger grafts, which you want to do when you do penetrating keratoplasty. And obviously, because you are not using tissues with good endothelial cell count, when you peel off the decimus, you can virtually take any tissue from the eye bank, which is optically clear. Surgical technique which is quite popular is the big bubble technique described by Anwar and Tishman, where you inject air at about 80 to 90% depth of the cornea, and that creates this bubble, which is a separation of the decimus from the stroma, or the duas layer from the stroma, and then you remove the anterior, the stromal tissue, replace it with a full thickness donor tissue. Between anterior segment OCT plays an important role in deciding which patient you would like to do a DALK, which eye penetrating keratoplasty, because sometimes the cornea has a lot of scarring, the risk of perforation increases when you try to do a big bubble technique, or sometimes in such cases you can do a manual technique of lamellar keratoplasty. So that's an important rule that you can follow up in your patients, especially if they have any corneal scarring. Although when you have patients with high drops, heel high drops, like in this case, we still do deep lamellar keratoplasty. I think with experience you can do that. They may not achieve 6/6 vision, but sometimes with their own endothelium, if they have 6/8 and 6/12 and they are happy, I think that's much better than doing a penetrating keratoplasty and long-term usage of steroids, risk of glaucoma and cataract, and the obvious risk of rejection. This is a patient who had a penetrating keratoplasty for keratoconus almost 25 years back. She came back with ectasia of a graft-close junction and with a cell count of 690, and when we looked at it, and this graft was still optically clear, we went back and did a large diameter manual lamellar keratoplasty, and she got back almost 6/9 vision, and the graft is still clear, and because she was not using any steroids prior to that, we still have maintained her on low dose steroids. The other advantage is that when you do a DALK, you can use any donor tissue. This is a 14-year-old boy with very advanced keratoconus, and the tissue we got was from a 90-year-old donor, and this obviously would not have used for a penetrating keratoplasty, but in DALK you can still do that, so that's another advantage of this. And the best part between the two is that when you do a specular post-PK or post-DALK, you can look at that, and although by looking at the graph sometimes you might miss out which one is which, but when you look at the specular image, it is very clear which one is a DALK and which one is PK. So if you look at some of the results, even in DALK, whether you manual near decimates or you do a big bubble going right up to the decimates, the visual results in both the groups are quite good. And although the manual DALK, when you are leaving behind some amount of residual stroma, the visual recovery takes a little longer. But in this series, at a follow-up of 30 months, in both the groups, the best corrected visual acuity was quite similar, and the endothelial cell loss was only about 11 to 13%. This report from the American Academy published in Ophthalmology in 2011, they looked at all the reports published on DALK and PK, and they looked at the overall outcome, and they concluded that DALK is comparable to PK if you look at the visual acuity outcome, and it's superior for the preservation for endothelial cell density. It has theoretical safety advantages intraoperatively as the eye is not open, and it's a good option for visual rehabilitation when the endothelium is not compromised. Coming to more specific studies where in subset of keratoconus they have looked at the outcome of DALK and PK, and the next 3-4 papers that I'm going to show, almost all of them have similar conclusion that they look at that when you bear the decimets, like you do a decimets bearing DALK and you PK, the results are exactly the same. Although when you do a manual DALK and you have some amount of residual stroma, the visual acuity may be slightly less compared to PK. And the graft survival is also, in this, because the follow-up is only 12 months, they say that the graft survival is the same in both the groups. But 1 year is the time when most of the grafts in PK also do very well. Now here, in this another paper from Javadi, which was published in Cornea, and looking at comparison of DALK versus PK in patients with keratoconus. They had 81 eyes of 81 patients, half of them underwent DALK and 35 almost had PK. The refractive error in both the groups were quite similar because the suturing technique in both is the same. So I don't think that a DALK gives you more advantage in terms of, although initially people felt that in a DALK, because you're not opening the eye, you can do early suture removal, but over a period of time we have realized that if you remove sutures pretty early, you can induce much more astigmatism. So in terms of the induced astigmatism, it is quite the same. The best corrected visual acuity is also the same. In this paper, they also looked at the contrast sensitivity and high order aberration, which were also comparable. Another paper which came out in International Journal of Ophthalmology in 2012. Here again, they compared the two groups for patients with keratoconus and 30 eyes DALK, 30 eyes PK. And this was a prospective study, and when they looked at it, they found that the visual acuity again was comparable between the two groups, including the contrast sensitivity. So basically, the conclusion was the same as what we have seen in the earlier paper. Looking at endothelial cell density, these are two papers that looked at the endothelial cell density between the two groups of DALK versus penetrating keratoplasty. And they found that long-term model predicted graft survival endothelial cells are higher after DALK than PK. So in fact, the average 5-year post of endothelial cell loss was only about 22% as compared in DALK compared to 50% in the PK group. So basically, in conclusion, surgical interventions are often necessary in the management of advanced keratoconus. DALK visual outcomes are comparable to penetrating keratoplasty, and DALK is superior with regards to preservation of endothelial cell counts and graft survival, and also reduced complications compared to PK. And at this point of time, I think PK is no longer the optimal choice or not the first choice when you are thinking about doing a surgery in a patient with keratoconus. So although at some point of time we used to say PK is the gold standard, and this was at the era when you were doing manual lamellar keratoplasty and the visual outcomes were obviously not as good as penetrating keratoplasty, but with the advent of the big bubble technique, with the kind of vision that you get, it doesn't seem appropriate that for your patient where, young patient, most patients with keratoconus are young, so where you can do a DALK, I don't think you should be performing a penetrating keratoplasty. I'd like to invite you to the second national meeting of Cornea Society of India, the Keracon 2014. This is on 20th and 21st of December. More information on the website corneasocietyinIndia.org. Thank you.